Hey everyone, Ronnie here from IKN. Thanks so much for joining and welcome to the next masterclass. This time it's on the neck. And as we'll go through in a few minutes now, when we think about the neck, which most people think as the cervical spine, the collection of cervical vertebrae, we tend to think of it more as the cervical spine equaling the interaction between the head and the rib cage and the thoracic spine. Okay, and the reason that is because it simplifies the way we organize how segments interact as we apply stress to the muscular tissues. Okay, behind all interventions, behind all exercises, they really are just vehicles of stress application. But one of the key things that I think we need to consider is, what is the arrangement of segmental interactions when we're applying stress to the system? Because one of the key components of our system and our approach as a whole is towards restoring variability. So when we're trying to restore variability to the cervical spine, we need to consider how the vertebral segments are interacting with each other, but sometimes going too narrow and using the interaction between cervical vertebrae to guide what kind of exercises, what kind of rehabilitation strategies you're going to use can be too much of a narrow focus early on. Whereas when we look at the head and the ribcage spinal interactions, then it just gives us a nice kind of initial entry point to organize segments as we apply stress. And we'll discuss that, of course, over the next hour or so. Okay, so just to give you a quick insight into what we have planned for this masterclass, we're first going to go through just some general features of our IKN approach process. We're then going to talk about a neuromechanical lens. We're then going to go into some of the features of our framework. And then we're going to look at some local segmental interactions. We're going to look at some assessments. And then we're going to go through some case studies. And then, of course, some interventions, some loading strategies. Okay. So firstly, going into some of the features of our approach process. So this is kind of the roadmap that we kind of follow to work through our course material, because when you're looking at things through a neurological and a musculoskeletal lens, there's lots of features and variables that we need to consider. But because there's so many variables, we need to simplify the thought process there. So we need to have a basic blueprint or framework that guides how we're viewing the interaction between multiple systems across the anatomy, but features that are universal across all individuals. So when we look at these neuromechanical features here, what we're looking at is the intrinsic properties of our movement system that help us manage forces and manage perturbations. And we split these into neural, muscular, joint, and attentional features. But these are essentially the design features of our movement system that, like I said, are universal or consistent across all individuals. Okay, so if we skip a slide now and we look at the skeletal design of the anatomy, and if you join past masterclasses, we typically discuss this kind of overarching neuromechanical feature where we have, especially if we're looking at things through a segmental lens, we're looking at the segmental arrangement of the midline region relative to the limbs. So if we look at the segmental arrangement of the vertebral column, the space between segmental interactions is very, very small compared to or if we look at the segmental interaction between C1, C2, C2, C3, very, very small distance, versus the interaction between the shoulder and the elbow, for example, the interaction between the humerus and the glenoid through the scapula, and the interaction between the humerus and the radius and ulna. There's a very large distance there. Okay, so when we have this very small distance, proximally, we have a larger distance between segments through the limbs. And then when we move into the hands and feet, within the hands and feet, we have smaller segmental interactions as well, or a smaller distance between those segmental interactions. So from proximal to distal, we go from more complexity in segmental behavior to more simplicity, and then finally to more complexity. And that distribution of complex segmental interactions to more simplicity, where we have a larger distance between segmental interactions, to more complexity, actually makes the system much more controllable. Okay, because you can imagine if you had a humerus that was segmented like your spine, for example, and a radius and ulna that was segmented like your spine, that would be a very difficult upper limb to control because there would be lots of joint angle changes, which means there would be lots of muscle length changes, which means the nervous system would be bombarded with sensory information, and it would be very difficult for the nervous system to coordinate appropriate muscle activity to control movements of the upper limb in terms of how it manages forces from the external environment. So that, like I said, this is a design feature of the anatomy that's universal, consistent across all individuals. Okay, nobody has a humerus that's segmented like your spine. But because we have a non-segmented structure like the humerus, it means we have to have certain muscular features to help transfer forces across those broad surface areas between the elbow and the shoulder, where that's where the biceps and the triceps become so important. Like the rec fem and the hamstrings and the lower limb. These biarticular muscles become very important to distribute forces across broader surface areas. Because when we look at the spine, for example, we can distribute motion across each individual vertebral segment. Each vertebral segment contributes some range of motion to spinal rotation, spinal flexion, and other directional motions through the spine. So that can help us share forces and distribute forces. But when it comes to sharing force across a non-segmented structure, we need to have certain muscular features to compensate, so to speak. Okay, so that's just one of many muscular design features and segmental design features. A neurological design feature, for example, would be the organization neurologically, where the nervous system has more of a tendency to shift more conscious control into the hands and feet and more subconscious control into the proximal tissues. Okay, and that's secondary to the organization of the cerebellum mainly. Okay, so again, that's just the overarching neuromechanical feature. Neuromechanical features don't specifically guide exactly what you do from a rehabilitation perspective, but it does form a general blueprint of how we're going to restore the low capacity of the system to be able to handle forces that are impacting our movement system. Okay. So, for example, if we consider this difference in skeletal arrangement, and we appreciate that muscular tissues are going to have a different behavior as well, we can appreciate that the upper limb takes on a much different role compared to the midline region. The upper limb, because it's in direct contact with the external environment, means that it actually is directly interacting with the external forces impacting our anatomy. So we want to build an upper limb that has the capacity to manage forces, to give the midline structures, the cervical spine, rib cage, thoracic spine, head, the opportunity to express less muscle activity and express a bit more variability. Okay, and we restore the upper limb's ability to handle those forces. Not every client that comes to see you with neck pain, for example, is a situation where we have to build strength into the upper limb first and foremost. We may eventually work towards that, but some clients may need more local variability through a muscular lens and through a joint segmental lens, proximally first, before we move from proximal to distal to build out those capacities across the upper limb. Okay. The unique presentation of the client will just dictate the speed at which we work from proximal to distal, but we eventually want to start to progress into the distal components relative to the cervical spine. Okay. So again, that's just looking at the overarching neuromechanical features. And in order to look at these neuromechanical features, we don't necessarily need to consider the unique individual features that a client will present with. Of course, we need to do that in reality. But when we're discussing neuromechanical features that are universal across all individuals, we don't necessarily need to consider individual features while we're describing that. But of course, we'll need to pair these neuromechanical features with unique individual features. A client that comes to see you with right-sided neck pain, for example, may have unique past injuries that contribute to their pain experience or their sensitivity. They may have unique day-to-day movement habits. They may have unique symptom behavior, unique easing factors and aggravating factors. They may have unique beliefs about their pain. So those are all unique individual features that we would need to combine with neuromechanical features to ultimately, identify the best plan of action when we're trying to restore the low capacity of the system and improve variability. Sometimes to improve variability, you need to address the client's beliefs about their pain experience. Because sometimes that can be the thing that's maintaining an avoidance strategy or maintaining high levels of protective muscle guarding around the cervical spine. it could be secondary to an unhelpful belief about the capacity of their system. Okay. And then we're going to move into restoring variability. So we have to develop a step-by-step framework to restore that variability. And then, like I said, we integrate that with unique individual factors. That's based upon the neuromechanical features, and then integrating that with unique individual factors. And then we work into some assessment features. So how do we design a structured assessment plan to identify the current capacities that the client has access to? And that will help us determine the appropriate entry points to loading. Okay. And then we go through some loading rehabilitation features to establish how, when, and why we're loading based on the limitations that we've identified during the assessment process. But one thing that we also need to consider there is this separation in the intention of the exercises. And we will talk about this across the masterclass. But on one side of the coin, we have this idea of restoring variability from a muscular standpoint, from a neurological standpoint, from a joint segmental standpoint. On the other side, we have symptom modification. So because pain is so complex, there's many things that contribute to pain. We can't necessarily, draw a causal link between the position of a segment, the position of the scapula, for example, or the position of the head. We can't necessarily say that's the root cause of someone's pain experience because pain is so complex. So we need to understand whether or not we're doing something, we're applying stress to the system, we're utilizing an intervention to restore variability, or are we doing it to have an influence on a client's symptoms? Okay, there's a big difference between those two. Okay, so one of the main things that you'll see, and I'm just going to skip ahead to slide number 6 here so I can discuss it. One of the features that's discussed quite a bit, particularly when we're looking at cervical rotation, is the position of the shoulder blade, the scapula. And so this was a study looking at the influence of a depressed scapula, or shoulder blade, and its influence on cervical rotation. Now, one of the things that they do to characterize a depressed scapula is look at the relationship of the spine of the scapula relative to the second thoracic spinous process. And if the spine of the scapula is below the second thoracic spinous process, it's said to be a depressed scapula. So one of the things they do is they bring the scapula up into normal alignment, okay, and then recheck cervical rotation. And typically they find that improves things, because the thought process is that because there's a lot of tension through these cervicoscapular muscles, the upper trapezius, the levator scapula, for example, that may limit the excursion of cervical spine rotation. Okay, but then what people will say that we need to restore the normal alignment of the scapula into that position relative to the second thoracic spinous process. Okay, but one of the things that research often shows is that even though we use the biomechanical configuration of segments to guide our thought process when we're trying to, exercise or apply stress via exercise to the system, and to have an influence on symptoms, it can influence symptoms, it can influence pain. But what's often shown afterwards is that the actual kinematic arrangement or the biomechanical arrangement of these segments hasn't changed. So, for example, if we bring this individual scapula into a position where it's level with the second thoracic spinous process, and then we load the upper limb or we load the cervical tissues in a certain way, and the client's symptoms improve, we can't necessarily say that scapula was in a faulty alignment or that wasn't in an optimal position, for example. Okay, all we did was restore some variability to the scapula, and that may have contributed to the client's sensitivity. But if the scapula doesn't actually change its position, then when we check the kinematic or biomechanical configuration after the interventions, when we've achieved pain relief, if it hasn't changed, then we can't necessarily say that the position of the scapula was the cause of the client's pain, especially if they go back into a depressed scapula. So that's where we need to look at things through a restoring variability lens, where instead of saying we need to bring that scapula into a neutral alignment, why don't we just actually bring the scapula into more elevation and allow it to experience load when it's elevated? So if it's biasing more of a depressed position and it's handling load only in a depressed position, let's teach the associated muscular tissues around the shoulder to handle load in a more elevated position. Let's bring variability to the scapula instead of saying that it needs to be in a perfect position or an optimal position, and then say that because it's not an optimal position, that it's the reason for the client's pain. So hopefully you can see the difference there. That if pain changes, but the biomechanical configuration hasn't changed after the intervention, you can't use that mechanism to describe the reason for the pain relief. Okay, and that's why it's important to characterize your interventions through a restoring variability lens, where we're just trying to restore the capacity of the individual segments. If we're looking at this from a segmental lens, we're looking at the interaction between the head, the ribcage, thoracic spine, the scapula, the humerus, for example. How are these segments all interacting with each other, and how is this influencing the muscular behavior locally and globally around the head and neck region? If, for example, a client feels a reduction in their pain when we elevate the scapula, then yes, we can say that, again, that's a contributing factor to the client's sensitivity, but we can't say that's the cause of someone's pain. Okay. In reality, during the rehab process, your rehabilitation will be represented by both strategies overall, where we're trying to restore variability, but we're also trying to have an influence on the client's symptoms. Okay, but if we just chase pain, if we just use a change in pain as the variable that guides our thought process, then it can get very, very messy because pain is so complex. Okay, so that's really the key feature there, is understanding that, what's the intention behind your exercise? Are you doing this to have an influence on the client's pain, or are you doing this to influence the variability of the movement system, the muscles and joints? You're not doing it with an intention of changing pain. You're doing it with an intention of changing the variability of the movement system. Okay, and using that as a framework is very important, because then we're working with function. We're working with the capacity of the system to manage forces and handle forces. And generally, what we tend to see in clients experiencing persistent pain is a reduction in variability, a reduction in the variability of muscles, a reduction in the variability of segments and how they interact with other segments. We tend to see increased muscle activity during movement. We tend to see a slowing of the speed of movement. Those are just general characteristics, but we can say that a position of the scapula or a position of the head is more associated with a pain experience, because it's just too complex for that. So sorry about the rant there, but it's just something that we tend to put a lot of emphasis on because, again, pain is so complex. So then we move into some progression and regression features. So we try to establish variables that we need to target across the rehabilitation process. So we try to establish quantitative features and qualitative features. Quantitative features are those features that are easy to objectify. So we can increase the load or decrease the load. We can have high amount of load, moderate amount of load, low amount of load. We can change the duration, we can change the frequency, we can change the sets and reps. Qualitative variables are those muscular and joint interaction features. So what is the interaction between the scapula and the humerus? What is the interaction between the scapula and the head and the neck, or the scapula and the thoracic spine? How are we manipulating those muscle and joint behaviors as we apply stress to the muscular tissues and apply load and force to the system? Okay, we need to characterize both during the rehab process to ultimately progressively load and build and restore the capacity of our system to manage forces. Okay, so just quickly into a neuromechanical approach here. So this slide is based on the work of Carl Newell and his constraint-led approach, and it really just highlights the importance of looking at interactions. Before we were talking about local segmental interactions, the interaction between the scapula and the head, the scapula and the cervical spine, the scapula and the thoracic spine, the scapula and the humerus. So human movement is really the expression of lots of interactions, the interactions between the nervous system and the anatomy and the environment, because ultimately, when you consider the importance of forces and stress and loads acting on our system, most of the forces that act on our system emerge from the external environment. Okay, and then when you consider, what parts of the anatomy are interacting with the external environment, that's when you look to the distal components of the limbs, the hands and feet. The cervical spine doesn't directly interact with forces. The hand interacts with forces, and then forces are transmitted through the system and dampened by muscular tissues and dampened by, muscles moving through more length and joints moving through more range of motion to distribute those forces over a broader surface area. Okay. So that's why the capacity of the upper limb to be able to handle forces from distal to proximal can influence the expression of muscle activity and the representation of variability between the head and neck. Okay. So when we talk about distal to proximal and proximal to distal sequencing. This is really looking at the behavior of muscles and joints, but it's highlighted by the nature of the task. So when we're managing forces or handling forces, handling perturbations or disturbances from the external environment, because we're handling them from the external environment, that would represent more of a distal to proximal sequencing, where I want to build the capacities distally to handle those forces and then decelerate those forces and transmit those forces across the upper limb and then proximally. Okay, so it's more of a disturbance control or perturbation control or force distribution task, and that would be highlighted by a distal to proximal sequence. The distal to proximal sequence would characterize an individual constraint based on Newell's theory of constraints, whereas the idea of disturbance control and managing perturbations, managing forces, would be more of a task constraint, where we're trying to manage the forces acting on a system, versus force production, for example, where we're trying to overcome the forces, we're trying to act on the environment, we're trying to overcome those external forces. And if I want to overcome forces acting on my system from the external environment, I want to utilize more of a proximal to distal sequencing, because most of the muscular tissue mass is distributed proximally across my system. Okay, we have much more muscle mass around the shoulder, around the thoracic spine, head and neck than we do distally through the hands and wrists, for example. Okay, and there's a reason for that, because we can generate a lot more force when we initiate movement proximally, and we can drive a lot more speed of motion through the distal segment when we initiate things proximally. So it's that sequential movement of proximal structures first to then distribute that movement into the distal tissues. Okay, so like I said before, this is again a neuromechanical feature. So it's not a specific feature that will guide specific rehabilitation for an individual experiencing neck pain, but it's a general feature, it's a universal feature that will guide our overarching thought process. And this one here will mainly, characterize our progression with rehab, where we're trying to move from proximal to distal. And ultimately, if I have a client that comes to see me with an increased muscle guarding around the head and neck, or a pain experience around the head and neck, I eventually want to move into the distal components of the upper limb that interact with the head and neck, because I want to restore the capacity of the upper limb to manage and handle forces based on these neuromechanical features. But like I said before, it doesn't mean that every client that comes to see us with a current experience of neck pain, we're just going to drive load into the upper limbs or through the hand first and foremost. We're going to start proximally and then begin to work distally. Okay, so again, these interactions ultimately guide how we structure our variability. And again, just to go through just some other kind of restoring variability features, we characterize the variability of the neuromechanical elements through muscles and joints. Okay, because the muscles and joints are kind of easy to characterize in a way. A muscle tissue, if we're looking at things from a local muscular variability standpoint, we want to understand, can that muscular tissue handle forces with variable contractile behaviors? Can it handle forces with more concentric behavior? Can it handle forces with more isometric behavior? Can it also handle forces with more eccentric behavior? Okay, that's variability in muscular behaviors to manage forces. Can a joint express variability in terms of how the segments of that joint interact with each other as the muscular tissues are handling forces? Or do we just express a co-contraction around the joint, which will represent, a reduction in variability? Okay. Another important point to consider there is, neurological variability is muscular and joint variability. So there's no such thing as a neurological assessment, because when you assess muscles, when you assess joints, you're assessing the nervous system, because ultimately the nervous system is acting through the muscles, which influences the joints. Okay, so the nervous system delivers motor output to the muscles. The nervous system can receive sensory feedback from joints, from joint receptors, but also muscles. But it really produces motor output through muscular tissues. Okay, so even things like fascia, tendons, they can deliver sensory feedback to the nervous system, but the nervous system doesn't talk back down to the fascia, it doesn't talk back down to the joints. It talks back down to the muscles, and the muscles will influence the behavior of the joints and influence the behavior of the fascia. And that's just neurology 101. Okay. So when we're utilizing, when we're delivering rehabilitation, applying stress to the system, we split these muscle and joint features into two buckets. Okay. Now the reason we're going into our framework a bit more is because in past masterclasses, we've just kind of gone straight into the assessments, but I just want to give you a little bit more insight into what guides our overall thought process when we're actually delivering load and assessing the movement system. Okay, so we split these rehab features into two buckets of needs: local needs and global needs. Local needs would represent space and capacity, we call it, or local muscular variability and local joint variability. So like I said before, can the local muscular tissues, can around the head and neck, in this masterclass we're thinking about, can the muscles that connect the head to the cervical spine, that connect the head to the thoracic spine and the scapula, can these muscles express variability in their behavior when handling load? Can they express isometric, concentric, eccentric behaviors? And the local segmental interactions express variability. So when I'm trying to get some load through the anterior cervical spine, for example, can I do that in a way that expresses some dissociation between the head and the rib cage, where my rib cage can extend, my head can flex, so I can get that concentric load into the anterior cervical spine? Or am I doing it where my rib cage is flexed and my head is flexing? Okay, I'm still getting load into the anterior cervical spine, but the interaction of the segments, the head and the rib cage, thoracic spine, are expressing a different behavior. So a flexion of the rib cage and a flexion of the head would represent less variability because they're both flexing, whereas an extension of the rib cage and a flexion of the head, as I drive load into the anterior cervical spine, would express more variability from a joint segmental standpoint, because one segment is extending, the other segment is flexing. So that's how we're kind of guiding our general thought process. We want to work towards being able to handle forces with more variability, but it depends on whether you're using the muscles as your intention or the joints as your intention. Again, in reality, you're going to look at both. Sometimes you may bias more load to the muscular tissues without trying to worry about what happens from a joint segmental standpoint. Other times, as you'll see in some of the interventions that we go through, if a client is very sensitive to flexion, for example, of the head, but they can't really concentrate flexion through the cervical spine, you may see a flexion of the rib cage and thoracic spine. So sometimes we might actually want to begin loading the tissues directly around the cervical spine while the segmental interactions actually express less variability, where they're moving in the same direction. Based on coordinated research, they would characterize that as an in-phase pattern. Or based on Nikolai Bernstein's work, he would characterize that as a freezing strategy or a freezing pattern. But we're allowing the segments to express that interaction based on the client's symptoms, because it's much more challenging to handle load through muscular tissues when joint segments are expressing opposing behaviors or opposing directions, where one is extending, one is flexing. It's much easier to get load into the anterior cervical spine, for example, the cervical flexors, when both segments are flexing. Okay? But we'll talk about why we're going to do that and then how we can progress things based on a variability perspective. Okay? And then the other bucket of needs is based on this coordinative need, this global intermuscular and interjoint variability need. And this really represents the ability of the upper limb as a whole to handle forces without the neck and the associated local tissues between the head and neck expressing heightened levels of muscle activity. So coordinatively, can I allow the upper limb to coordinate and share forces across the upper limb without needing the proximal structures to express heightened levels of muscle activity? That would be more of a coordinative view of movement. So intermuscular means between muscles. So can I share those forces between the finger and wrist flexors up into the bicep and tricep, for example, without the scapular muscles having to elevate and express more muscle activity proximally, for example. Okay. And then looking at the head and neck within the context of the rest of the spine, can the head and neck couple with the rest of the vertebral column? Can the thoracic spine and the head couple with the pelvis, for example? So in order to get an actual rotation through the vertebrae, we really need if we're looking at the thoracic spine, for example, if you're sitting down right now, for example, and you rotate your thoracic spine, your rib cage, your chest to the right-hand side, what you might notice is that your pelvis begins to move in the same direction, and you might notice the left femur begin to shoot forward. That represents a rotation of the pelvis in the same direction as the thoracic spine. So you're not actually getting a huge amount of rotation through the vertebrae. at all. You're really just rotating about the pelvis between the femur and pelvic interaction, okay? If you wanted to try and concentrate that rotation through the vertebral column, you'd have to fixate the pelvis and then rotate the chest. So relative to the thoracic rotation to the right, the pelvis is actually rotating to the left. So you're actually getting that rotation through the spine. The same idea exists between the head and neck. If you're setting someone's cervical rotation and you have them look to the right and you see this turning of the chest in the same direction, then there's not really much rotation happening in the neck at all because the thoracic spine is rotating in the same direction. So we would need to restore what's known as dissociation between those individual segments, okay? But you can have dissociation in multiple planes. So for example, if I rotate my head to the right now, my head is rotated to the right, but my thoracic spine is rotated to the left, which allows the cervical spine to express some rotation. If they both rotated in the same direction, then there's no rotation occurring there. If I was to flex my head, but my rib cage flexes very quickly with that, and again, I'm distributing that flexion into the thoracic spine. I'm not able to concentrate that flexion through the cervical spine, particularly through the upper cervical spine. I'm distributing that flexion into the thoracic spine. So to concentrate flexion into your upper cervical spine, you would need to extend the rib cage, thoracic spine, and then flex the head. Okay, so we're seeing, can the client actually demonstrate that ability to concentrate extension into the upper cervical spine? So that idea of concentrating movement versus distributing movement is also very important to consider there as well. Okay, so that's that coordinative lens. How does this local region around the head and neck, which is what the intention is for this masterclass, how is that interacting with the upper limb as a whole? How is it interacting with the rest of the spine as a whole? Okay, but again, looking locally, how are the muscular tissues, around the head and neck? How are they expressing variability? Okay, so those are two separate buckets of needs. So now let's look at some local segmental interactions. So like we said before, we're looking at the cervical spine as a representation of how the head interacts with the rib cage and thoracic spine, okay? And that allows us to look at, not just cervical spine motion, but look at how the head motion and how thoracic spine rib cage motion will have an influence on cervical spine motion. Okay, so we can look at this in many different directions. So we can look at head flexion, head extension, rotation of the head, side flexion of the head. We can look thoracic flexion, we can look at thoracic extension, rotation of the thoracic spine, and side flexion of the thoracic spine. Okay, each of those directions and how they interact with each other, the head and the thoracic spine and rib cage, will have an influence on how the cervical spine moves. So for example, if they both move in the same direction, I'm not really getting a huge amount of rotation in the cervical spine. If they move in opposing directions, I'm getting a lot more rotation in the cervical spine. Another key rehabilitation feature that we talk about is we want to try and restore sagittal plane capacities first, okay? Because there's so many movement options available across the entire anatomy, we need to, have a sequence as to, how we restore motion, particularly when, some motions are painful or when multiple motions are sensitive and painful. So we generally look at sagittal. So when we look at head flexion, for example, like I said before, we want to be able to concentrate that flexion at the upper cervical spine. And then we want to be able to ultimately decelerate or slow down that flexion of the ribcage. Because if I begin to flex my head and I can't concentrate that flexion at the upper cervical spine, and very often what you're going to see is a quick flexion of the ribcage. And then to get further, what you're often going to see is just more of a translation of the head forward, where we're not really getting any flexion through the cervical spine at all. So that's why we talk about this lower cervical extension early on, or this delayed flexion, where I want to be able to get that flexion from the upper cervical spine and then begin to allow the upper thoracic spine, lower cervicals to flex. If I'm flexing them very, very quickly, then I'm not able to concentrate that flexion through the upper cervical spine. When it comes to head extension, again, I want to be able to, of course, concentrate some extension through the upper cervical spine, but then I also want to distribute that extension into the lower cervical and upper thoracic spine. Okay, so I can actually get my head into a position where it's almost parallel with the ceiling. Okay, if I flex my rib cage, and if I flex my rib cage thoracic spine, I'm ultimately flexing the upper thoracics and lower cervicals. And then if I try to extend, I'm not going to be able to get my face parallel to the ceiling there. I'm concentrating that extension there through the upper cervical spine. But if I allow the upper thoracic spine and the lower cervical spine to extend, I'm distributing that extension across the cervical spine. Okay, so that's something that we want to ultimately achieve as well. Okay, so ultimately we're looking at this from a local segmental capacity standpoint. Can the head and rib cage, thoracic spine express triplanar dissociation, and can we restore some low capacity through the muscular tissues as we begin to restore some dissociation? Okay, so again, remember, we're not working with a unique individual client now with unique symptomatic behaviors. We're talking about the general features that we're looking at to guide our thought process when restoring the low capacity to the local region around the head and neck. So we're thinking, can the head flex? Can the thoracic spine extend? Okay, can the head extend and the thoracic spine flex and extend, like we spoke about there? Okay, so with head flexion, for example, we want the head to be able to flex with thoracic extension. Can the head extend with thoracic flexion? Okay, that's dissociation. So head flexion with thoracic extension, but then head extension with thoracic flexion. Okay, that's dissociation movement in opposing directions. But like I said here, with head extension, to get cervical extension, we ultimately want the extension to be distributed across the cervical spine into the lower cervical spine and then upper thoracic spine. When we look at it into the transverse plane, we want the head to be able to rotate in the opposing direction of the rib cage and thoracic spine. So can the head rotate to the right as the thoracic spine rotates to the left? When we look at the head-neck interactions in the frontal plane, we want the head to have the capacity to side bend without the scapula and rib cage elevating on the opposing side. So when I side bend my head to the left, can I keep my scapula and rib cage, fixated in position to allow for the upper trapezius to express more eccentric behavior, for example? Or when I side bend to the left, if I see the right scapula begin to elevate, the rib cage begin to elevate on that side as well, which would demonstrate a lack of variability. So you can see again, we have, the capacity to express dissociation in multiple planes, but we want to work on sagittal plane dissociation first. Now, also, when we look at within the head interactions, we can look at the interaction between the eyes and the skull. So think of the eyes as just another segment that we want to have the capacity to dissociate relative to the head. If the eyes can't dissociate, typically the eyes and the head are going to move in the same direction. You can also look at this within the context of the mandibular interaction with the skull. So can the mandible dissociate, move independently of the head and neck? One of the things that you'll often see is if you ask a client to protract their jaw, what you'll often see is if they can't concentrate that protraction at the mandible, you're often going to see a protraction of the head where the head juts forward to facilitate, and that creates more of an extension through the upper cervical spine. Whereas if we wanted to create dissociation in those two movement behaviors, we want the head to have the capacity to retract and the mandible to have the capacity to protract, okay, to create that space posterior to the mandible, okay? So those are some ways we can look at the variability of the segmental interactions within the context of, how are we going to begin loading these muscular tissues, okay? So hopefully that makes sense in terms of what our overall framework is, why we're going after variability. And next we're going to look through some assessments. Okay, so let's look through some assessment strategies. Okay, now we're going to look at the assessments within the sagittal plane first. Now, we like to look at spinal flexion initially. Spinal flexion gives us a nice representation of how the entire spine is distributing flexion. Okay, so we'll pull up the video here so you can see that, because you'll tend to see a few different strategies. So one of the things we're looking at is, can the neck actually flex? Because what you'll sometimes see is someone begin to flex the spine and they'll keep their head extended. There could be many reasons for that. Maybe they're avoiding that eccentric demand on the cervical extensors. Maybe they're trying to avoid any tensile load into the neurological structures, for example. But one of the things we're looking at here is, you'll see I have a lot of thoracic flexion there, but we're looking to see, can the thoracic spine actually flex with the head here? because it's a distributed flexion, can the scapulae actually protract to one, facilitate a thoracic flexion, but also to bring the upper limbs into a position where they can actually handle forces and manage forces. If the upper limb struggles to handle forces, what you'll often see is the scapulae begin to retract. Okay. So we're not necessarily looking to see can they touch their toes, but we're just looking to see can they distribute that flexion across the spine. Okay. Some things that you'll often see is something like this, where you'll ask the client to reach down towards their toes, and you'll see that head begin to extend. You may see a challenge in allowing that thoracic spine to be able to flex. So we're not really getting a huge amount of flexion distributed across the spine. We're not really getting a lot of scapular protraction here, which again may influence the capacity of the upper limbs to be able to handle forces. It may also influence the variability of the muscular tissues that connect from the cranium, cervical spine, to the scapula. Upper trapezius, levator scapula, for example, those structures will be important to consider their local muscular variability. So if a client demonstrates this movement at the start, you can note that, but then see if they have the capacity to distribute that flexion. Sometimes it's just a strategy they use, but if you notice that if they struggle to distribute flexion across the spine, this is something that we would definitely need to address during the treatment process and the rehabilitation process. Then we're looking at head flexion in a little bit more of a concentrated manner, a little bit more locally. So like I said before, we're looking to see, does the head have the capacity to flex and concentrate some of that flexion through the upper cervical spine, and then ultimately delay that ribcage thoracic spine flexion. Ultimately, what we're looking for is to see, can the client get the chin to the chest? Okay. Again, you're looking to see if the client has sensitivity, has discomfort with this. What you'll tend to often see is this quick flexion of the thoracic spine, where you may see the shoulders translate forward to facilitate that scapular protraction, to encourage thoracic flexion. So if a client is demonstrating this, for example, perhaps they have an inability to concentrate that flexion at the upper cervical spine and delay that flexion through the upper thoracic and lower cervical. Okay, so that may be a capacity that we want to work towards. Okay, if the client, for example, had a very, let's say here, for example, the first strategy we looked at, if, for example, the client had a very extended thoracic spine that couldn't flex, again, it doesn't mean that the reason for their pain is because they're stuck in thoracic extension, but just think of it through a variability lens. They lack a variability in thoracic movement. They may lack a variability in scapular behaviors. So if they're only able to concentrate flexion at the cervical spine and they're not able to distribute flexion into the thoracic spine, then this may also be something that we want to address. We may, in that situation, want to begin loading the cervical spine by distributing flexion into the thoracic spine and the cervical spine to ultimately load the tissues through the anterior cervical spine or the posterior cervical spine, for example. And we'll go through some of those strategies as well. But hopefully you can see that there. If you're seeing they demonstrate that they don't have the capacity to concentrate that flexion at the upper cervical spine. Okay. And then we're looking at head extension. So we'll bring that into the wider screen here. So we're just asking the client to look up, and we're seeing what kind of behavior does the thoracic spine, cervical spine, and the head express as the head looks up. Is the head able to extend? Can they extend through the upper cervical spine? And then can they distribute some of that extension into the lower cervicals and upper thoracics? Okay. We're asking the client, do they experience any symptoms, any sensitivity here? Sometimes what you may see in a client that already has a very flexed thoracic spine posture, where, again, there's nothing wrong with a flexed thoracic spine posture, but we need to understand, do we have variability in that thoracic spine behavior, that ribcage behavior? If you already have a very flexed thoracic spine, where the lower cervicals and upper thoracics are more flexed, and you have a client extend, they may not be able to achieve that full range of motion because they're concentrating that extension through the upper cervical spine, and they're unable to distribute that extension into the lower cervical and upper thoracic spine. So if a client's very sensitive to this, for example, we can say that this is a faulty movement or that it's not an optimal way to move, but the client just may lack variability in how they're distributing forces, how they're distributing movement. Maybe they're concentrating a lot of extension through the upper cervical spine that may be sensitizing the structures there. So we may want to distribute some of that extension as a component of rehabilitation. Okay, but you're not necessarily trying to, improve thoracic extension or lower cervical extension to fix the pain, but you're doing it to restore some variability between the segmental interactions. Okay, so again, that's how we generally kind of think through head flexion and head extension. We're considering, we're considering the behavior of the cervical spine within the context of head and thoracic spine interactions. Okay. Again, can the head extend as the thoracic spine extends? Can the head flex as the thoracic spine stays relatively extended and then begin to flex? Or are we seeing that quick flexion of the thoracic spine to demonstrate that they can concentrate that flexion through the upper cervical spine? But a nice kind of entry point to assessment is looking at spinal flexion. You can also look at spinal extension as a whole as well to see if the thoracic spine has the capacity to extend too. We also kind of discussed this as well. And this is a lot of people will look at the position of the scapula, for example, to get an idea of the behavior of the scapular muscles that connect into the cervical spine. Again, I think that is important if our approach is to restore some variability to the muscular tissues that connect the scapula to the cervical spine and the cranium. But we can't necessarily say that one position is more optimal than the other. We can't necessarily say that one is ideal and the other is faulty. We just have to look at it through a variability lens. Does the client actually have the capacity to move in the opposing direction? Can they move in the opposing direction and handle forces as they do that? Okay, so it changes your intention. Okay. Now let's look at the motion of the cervical spine in the transverse plane. So when we look at head and neck rotation, again, we're looking for between 80 and 90 degrees of rotation. So we're seeing generally, can the client concentrate that extension through the spine, or not concentrate extension, concentrate that rotation through the cervical spine? Or do we see a rotation of the thoracic spine in the same direction? Do we see a change in the behavior of the scapula, for example? Okay. So we're looking at that in both directions. An important thing to consider here is the dynamics of the spinous processes. So if, for example, I just jump to this video for just a second, bring that up into the full screen again. So when you look at that rotation of the cervical spine or the head to the right-hand side, for example, you'll see that the spinous processes actually move to the left. And then you can consider what muscular tissues connected to the spinous processes there. The upper trapezius would be one. And so when the head moves to the right, that's actually going to demand a little bit more eccentric behavior or lengthening through the upper trapezius on the ipsilateral side, secondary to the dynamics of the spinous processes. Okay, so it's almost like the head rotates to the right, but the spinous processes move to the left. And so that's why if somebody, for example, has a pain experience or a limitation in rotation of the head to the right, we may have to consider the eccentric behavior of the upper trapezius. Can the upper trapezius actually lengthen to distribute that motion across that muscular tissue? Okay, so that's generally an important thing to consider there. Now, what are some representations of a reduction in variability? So if we look at a video here, when we're looking at head and neck rotation, so what you'll tend to see is that when they rotate the head, you'll see an inability to concentrate. That's what I was saying there. They can't concentrate that extension through, concentrate that rotation through rotation of the thoracic spine, but they actually have to extend through the thoracic spine. So they can't actually get that rotation through the thoracic spine. They have to steal motion from another direction. Okay. Typically, when we move back into more of an extended position, we're moving into more of a close pack position that would represent less variability. Okay, so that's why generally, again, from a very, very, very general standpoint, we would almost always try to see if the client has the capacity to flex the neck first, because we're moving the neck into more of an open pack position where there's more variability. Okay, again, we're not driving the client into more extension. Of course, again, the cervical spine will express more of a lordotic curve, but we're not necessarily trying to restore the lordosis in the cervical spine. We're trying to restore variability across all the local segments, all the muscular tissues. Okay, so that would be a representation that we can't get that rotation through the cervical spine. What you may also see here is a rotation and then a driving of the scapula forward on the same side as we're rotating towards. Okay, oftentimes I find that clients will do this when they're trying to take up the slack in the muscular tissue, so it reduces the demand of the cervical spine to actually rotate. So sometimes, for example, you'll see when a client's trying to, let's say, rotate the thoracic spine, sometimes easier to view this through the thoracic spine and scapular interactions. So if I'm trying to rotate my thoracic spine to the right, for example, but I can't actually rotate through the thoracic spine, what you'll often see is an extreme or exaggerated retraction of the scapula on the same side to try and drag the upper limb into a position where I can actually reach for something, but I'm not actually getting that rotation through the thoracic spine. I'm actually getting it through a lot of retraction. Okay, so we're kind of stealing motion through the scapula there, for example, secondary to an inability to rotate the actual spinal structure. Okay, so oftentimes the scapulae will move a lot when the spine can't actually rotate. Okay, so that's tends to be, again, one of the thought processes. There's lots of potential reasons for this, but that's one of the reasons that we tend to see clinically, especially when we kind of break out and begin to assess the thoracic spine in isolation. When we see that scapula begin to protract very quickly to take up the slack in the upper trapezius, for example, we tend to see a limitation in thoracic spine rotation when we measure that in isolation. And then the most common one that we tend to see is a rotation of the head and the thoracic spine in the same direction, where they're unable to get that dissociation. So you can see a lot more of my face now because my thoracic spine is moving in the same direction. But if I had a limitation in cervical or head rotation and I can't look behind me, I'm going to move my thoracic spine in the same direction to position my eyes further behind me. Okay. And so if we look at the rotation of the thoracic spine, again, what we tend to do here, again, we're looking for the physiological range of motion. We're looking for at least 50 degrees of range of motion in the thoracic spine. We'll generally look at this in a seated position. But one of the things I want you to notice here is when I'm passively moving the thoracic spine, and I'm getting some active participation for the client here as well. I'm asking the client to rotate their spine to the left, and I'm providing passive overpressure. Because one thing that we like to do here is provide that overpressure in the end range of thoracic rotation. Because sometimes the client may feel they have good rotation, but when you apply that passive overpressure, the clients may feel a lot of discomfort in the thoracic spine, which would demonstrate to me that they lack variability in the ability to handle forces towards the end range of thoracic rotation. But one of the things that you'll tend to see here, and if you look at the pelvis now, if you look at the femur, you'll see the pelvis begin to rotate in the same direction as the thoracic spine. So it looks like I have a lot of rotation in the thoracic spine, but there's actually a lot of rotation coming from the pelvis. So one thing that we do here when we're assessing thoracic spine rotation is we'll position a block between the knees, ask the client to gently squeeze that, and then we'll begin to rotate the thoracic spine again. Okay, we can get really nitpicky with this if we wanted to and say, look, when we begin to see that femur moving backwards, again, which would encourage a rotation of the pelvis in the same direction, then we could stop the test. But generally, we're going to be using this as just a way to concentrate a little bit more rotation through the thoracic spine. Apply that passive overpressure. You can see she's not getting as much thoracic rotation here. But again, she's definitely getting through at least 50 degrees of range of motion there. In clients, you're looking for a glaring limitation. One of the things that we tend to do here as well to see if the thoracic spine is contributing to, or a lack of motion through the thoracic spine in terms of rotation, it's contributing to a lack of rotation in the cervical spine. Let's say, for example, Rachel here was limited in right rotation of the cervical spine. What we'll tend to do then is gently rotate the thoracic spine in the opposing direction, and then have Rachel repeat the rotation of the head to the right and see if there's any change. All that allows us to do is to concentrate a bit more rotation through the upper thoracic spine by encouraging the movement in the opposing direction. Okay, and it just allows us to consider, especially if the client's range of motion improves, which we tend to see often if the thoracic spine is contributing to the limitation, or if a lack of thoracic spine rotation is contributing to a lack of range of motion, we tend to see that change the range of motion quite quickly there. Okay, again, there's lots of other hypothetical reasons for that change in range of motion as well. But again, it just helps us direct our focus towards, a certain area, a certain region of the anatomy. Do I need to really, focus on restoring some motion through the thoracic spine here, or do I just need to concentrate that load through the cervical spine and condition the cervical spine to handle more force as we move through more range of motion? Or do I need to distribute some range of motion into the thoracic spine to assist the cervical spine? Perhaps the cervical spine is expressing, most of the range of motion. There's more force and more stress being concentrated into the cervical spine, and there's not much distribution into the thoracic spine, for example. So those are some things that kind of go through our mind. Okay, you can see how this unfolds from the top down. So we just added this video to kind of give you an idea as to what's happening through the pelvis. So again, we have Rachel rotating left and right there through the thoracic spine, but you can see that movement of the femur backwards, which again encourages that rotation of the pelvis to the left. Okay, so that would represent, again, a movement of the pelvis in the same direction, which would reduce the rotation of the spine. Okay, we're not actually getting that rotation through the spine at all in that circumstance. Here, we are able to get that rotation through the spine because we're fixating the pelvis. Okay, so next we'll look through some upper limb assessments. Okay, so let's move into some upper limb assessments. Now we're going to look at the variability of the humerus and the scapula here through humeral flexion. And humeral flexion is actually a very good representation of scapular variability, because during the early to middle phases of humeral flexion, the scapula has to have the capacity to protract to point the glenoid cavity into the sagittal plane to bring the humerus into the sagittal plane. And then as we move through the end ranges of humeral flexion, the scapula has to externally rotate and retract and posteriorly tilt with an extended thoracic spine to, again, bring the humerus into end range humeral flexion. Okay, versus humeral abduction, for example, where the scapula doesn't necessarily have to move through internal rotation via protraction or external rotation into retraction. It stays relatively retracted and externally rotated, where the glenoid cavity faces more laterally. Okay, the scapula, again, restoring variability to the scapula is very important when we're looking to restore good load sharing coordinative capacities across the upper limb as a whole, but also when it comes to restoring local variability across the cervical spine as well. So looking at humeral flexion is very important. It's also a good measure to see, does the client have the capacity to extend the thoracic spine? So for example, if you have a client that's very flexed through the thoracic spine and you try to have them flex the humerus, oftentimes what you'll find is they can't actually, if they can't extend the thoracic spine, it's going to be very difficult for them to be able to retract and externally rotate the scapula, which is going to make it very difficult for us to get some load into the upper trapezius, for example, through the middle traps, for example. Okay. Again, if in the early phases, let's say, for example, you have a client with a very extended thoracic spine and they really struggle to protract the scapula to bring the glenoid cavity into the sagittal plane, then that's going to represent an inability of the tissues medial to the scapula to express more eccentric behavior. Okay, so another representation that you often see in clients is if a client can't upwardly rotate the scapula. Very often what you're going to see is an elevation of the scapula to try and drag that scapula upward to bring the humerus above the head. But it's not actually occurring through upward rotation. Sometimes that can, allow clients, or mean that clients experience some sensitivity, some discomfort through the upper trapezius. It doesn't mean that that's the cause of their pain experience, but it can be a contributing factor, and we may have to restore variability in those muscular tissues, those segmental structures. Okay. So first and foremost, we're looking to see, can they express full range of motion? Okay. To get the full range of motion, we demonstrate to us that, again, the thoracic spine has the ability to extend, the scapula has the ability to externally rotate. What you'll often see is something like this sometimes if they can't get through full flexion. So what you're seeing there is a very quick internal rotation of the humerus. If you were to put your right upper limb out in front of you at 90 degrees of humeral flexion and you internally rotate your humerus, what you'll often notice, and if you continue to internally rotate, you'll feel how your scapula begins to upwardly rotate and elevate. So if a client struggles to express that upward rotation of the scapula, very often you'll see this early humeral internal rotation, almost to try and drag the scapula into upward rotation, okay? So you'll often see that occurring there. And then what we're looking at here is we're looking to see, what we actually want to see. So when we look at the second representation there, we want to see the scapula have the ability to protract to keep that humerus in the sagittal plane. Okay, because again, if the scapula doesn't protract, the glenoid cavity doesn't face forward. Sometimes you'll see this deviation of the humerus into the scapular plane because the scapula can't actually protract to bring the humerus around to the sagittal plane. And then we'll see towards the end range, you'll see then that humerus begin to internally rotate. Because if you bring the humerus kind of closer to 160, 170 degrees of flexion and you begin to internally rotate, you'll naturally feel how the scapula begins to externally rotate. So that's why humeral internal rotation is actually very important to achieve end range humeral flexion, because it couples with an external rotation of the scapula, and that couples with an extension of the thoracic spine. Okay, so very important to consider those features there. So we're looking for pain sensitivity, we're looking for fear of motion, we're looking for a lack of muscular and segmental variability. We're looking at upward rotation, elevation, and we're considering the influence of humeral internal rotation there. So if, again, we don't have good upward rotation, then we may move the humerus into internal rotation to drag that motion there, to drag that scapula into upward rotation, okay? And we can consider things through two separate interactions. Does this demonstrate a lack of variability between the scapula and the thoracic spine? Or does this demonstrate a lack of variability between the scapula and the humerus, for example? Okay, so again, there's going to be different muscular tissues that connect the scapula to the humerus relative to the scapula and the thoracic spine. So we may need to look at other rotational behaviors between the humerus as well relative to the scapular spine to get an idea of how the muscular tissues are expressing variability. Because if I have a lack of variability at a neighboring segment, for example, that can influence the workload of another neighboring segment too. In terms of variability, again, we can't say that a lack of variability at the shoulder, for example, is going to cause pain at the cervical spine, because then everybody with a limited rotation in the humerus, for example, or a limitation in rotation at the scapula will experience pain in the cervical spine. So that's why you can't say those things, and that's why you have to separate symptom modification from restoring variability. But it also gives us a nice insight into understanding, can the upper limb actually handle and share forces? We do need to allow for that scapula to protract to bring the humerus into the sagittal plane where we have to interact with the external environments. Okay. Of course, we need that scapula to be able to retract and externally rotate to reach into the frontal plane and interact with forces. But generally, the ability to bring the humerus into the sagittal plane is very important to build an upper limb that can handle forces and shear forces well. So we can consider this within the context of how the upper limb can handle and shear forces, and then what kind of impact might that have on proximal variability. Might it be a case where we're seeing heightened levels of muscle activity and limitation in variability at the cervical spine, secondary to a lack of load sharing across the upper limb, for example, and not secondary to a lack of local muscular variability. So sometimes we don't necessarily need to do a lot of local direct work on the cervical spine, but we may have to actually build the capacity of the upper limb. And that's where the assessment really comes into play here. Okay, so let's look at two different case scenarios that may represent individuals that have different needs. Okay, so case one, we have a client with persistent right-sided neck pain of gradual onset, worse with neck flexion. So as this client flexes the head, again, they feel pain, they feel sensitivity through the right side of the neck, but they have a history of right anterior shoulder pain. So when a client, tells you that they have a history of upper limb related pain or an upper limb injury in the past, we need to be considering the load capacity of the upper limb as a whole. Okay, we may need to consider that what we're seeing, what we're observing proximally may be secondary to poor distal load sharing qualities. Okay, but obviously we would need to objectively assess things to strengthen that hypothesis. Okay, so first we're looking at spinal flexion. we see a limitation in thoracic flexion. Okay, so this client's not getting a distribution of flexion across the cervical spine and the thoracic spine. So perhaps we need to restore some thoracic spine flexion, some ribcage flexion, to distribute some flexion across the cervical spine as well. What if, for example, this client is concentrating motion at the cervical spine and not actually able to distribute motion across other neighboring regions as well? And that may be influencing the sensitivity of the local region. Neck flexion is limited and sensitive. Neck rotation is limited bilaterally, but no pain or discomfort. Shoulder flexion, she has full range, but has an early internal rotation of the humerus and struggles to flex the humerus with an external rotation of the humerus. Okay, because when you externally rotate the humerus and you flex, you challenge the ability of the scapula to upwardly rotate on its own without using the humerus to drag the scapula into upward rotation. Okay. So in these situations here where we have a client with limited thoracic flexion, a pain experience with head and neck flexion, then very often we'll actually begin to, especially if we're trying to directly load here. So when we go through these rehabilitation strategies, we're talking about strategies where we're directly loading the head and neck. Okay. In reality, when we have a client in a clinical situation, we may have to simultaneously load the upper limb as we're doing some direct load through the cervical spine, through the head and neck. So we're going to separate these rehabilitation strategies through direct work and then indirect work. Direct work meaning we're trying to direct load and concentrate load into the cervical spine tissues. Indirect work meaning we're trying to facilitate better load capacities into neighboring tissues, into neighboring segments to influence the variability of the cervical spine. Okay. So if the client's sensitive with head and neck flexion and they have limitations in thoracic flexion, then generally one of the key things that we'll work on first is trying to facilitate thoracic flexion, but then couple that with head flexion. So we're encouraging the system to distribute flexion first. And then we can progress to concentrating that movement into head flexion. Okay. And then we can begin to challenge the upper limb capacity to perturb the behavior of the head and neck. Okay. So let's say, for example, secondary to that right anterior shoulder pain, she's not able to handle forces well through the upper limb, and potentially the muscular tissues proximally around the head and neck need to express much more muscle activity, which is represented through less variability in muscular behavior. Okay, so maybe we need to build that capacity through the upper limb, but simultaneously try and reduce a habitual strategy of expressing heightened levels of muscle activity proximally. Okay, but that one may be an important capacity to address secondary to the subjective history, the history of right anterior shoulder pain that perhaps wasn't rehabilitated properly. Case number 2, we have a client with persistent right-sided neck pain, but she had a concussion 3 years ago when her symptoms started. Okay, so this is a different situation where there was direct trauma to the head and neck. So again, we need to consider what happened in the past, what the prior treatment comprised of, but we need to consider here that maybe we need to do a lot more direct work around the head and neck and restore some local variability to the head and neck, to the thoracic spine, to the rib cage where those cervical tissues connect with. Okay. Again, past treatment involved neck stretching and scapular strengthening to no avail, but again, and likely because there wasn't any kind of direct work done to restore variability to the local structures around the head and neck. If we look at spinal flexion, good thoracic flexion, good scapular protraction, again, which couples with thoracic flexion, multi-directional limitations in the neck, so limitations with head flexion, head extension, and rotation, and sensitive. This client is limited in rotation of the thoracic spine bilaterally and has limitations in shoulder flexion, again, which is really humeral flexion, bilaterally. She's poor thoracic extension. Okay. One of the things that we will discuss is that if you have a client that has limited thoracic extension, meaning they're biased towards thoracic flexion, we wouldn't necessarily just drive the client over a foam roller and try to force them into more thoracic extension. Because what you're doing when you move into thoracic extension is you are moving towards a direction of less variability within the thoracic spine, because you're moving towards more of a closed pack position. Okay, so if we have a client that is biased towards flexion and limited in extension and rotation of the thoracic spine, we would be more inclined to rotate to improve that rotation of the thoracic spine first before we begin to drive more thoracic extension, mainly because we're moving towards the direction of less variability when we just jump right into thoracic extension. Okay, so we want to try and improve. We have good variability in thoracic flexion. We can hold that position. We have to consider also, can we handle forces in that position? Same thing with thoracic rotation. We have limitations there. We need to improve that, and then we can begin to restore some variability into thoracic extension. And again, the limitation in shoulder flexion or humeral flexion demonstrates that limitation in thoracic extension as well. But we also need to consider there, the variability of the muscular tissues around the scapula or in the humerus that can contribute to a change in variability proximally. So again, typically when we have multi-directional limitations around the head and neck, we're dealing with a co-contraction of muscles through the cervical spine. The co-contraction is where we have simultaneous contraction of the muscular tissues connecting to individual segments that limit range of motion in multiple directions. Okay, so co-contractions can be helpful in situations where we're dealing with very, very high forces at high speeds, for example, but not necessarily when we're looking at submaximal movements and we're dealing with submaximal forces, where we do want to demonstrate the ability to maintain some variability in muscular behavior and joint behavior. Okay. Typically, when we're dealing with a very sensitive neck, a very sensitive cervical spine, then we can focus our attention to the neighboring limitations first, perhaps again distributing some of that motion into the thoracic spine through restoring some rotation can actually help desensitize the cervical spine. Again, that's just a hypothesis, but again, we're looking at just restoring some variability. But generally, this is what we tend to see in a lot of cases, where if you have a lot of sensitivity in one area, you don't have to necessarily drive rotation directly into that area early on, but we can facilitate some motion into a neighboring area to then begin to distribute that motion into the thoracic spine and neck at the same time then, okay? And then we wanted to restore that local load sharing capacity of the cervical spine, okay? So generally at the very beginning here, we're thinking, does the head and neck need direct load to restore local muscular and segmental variability? Or do we need to actually restore more indirect load capacities where we're actually restoring load capacity through the upper limb and allowing the proximal region around the head and neck to express more variability, secondary to improving load through the upper limb? Okay, so we would characterize these strategies as indirect perturbations, and we'll go through some of those strategies as well, where we're trying to simultaneously drive load into the upper limb while trying to reduce a certain behavior through the head and neck. Okay, so next we're going to go into some of the rehabilitation strategies. Okay, so moving into some local sagittal plane limitations, and we're going to focus on flexor loading here first. Okay, now when we're loading the cervical flexors, we need to consider the interaction between the head and the rib cage and thoracic spine. And again, just a quick note on, when we're storing length or eccentric behavior into the anterior tissues. Of course, we do want the head to be able to extend, okay? In order to allow for a little bit more extension through the head, we want the thoracic spine to be able to extend as well. But in order to get length into these tissues, we want the rib cage to be able to flex through an exhalation without the spine actually flexing. So that can seem a bit confusing there, because we want the rib cage to flex without the thoracic spine flexing in that situation. Okay, so for example, if you were to extend your head, you extend your thoracic spine, and you hold that extension, and then you begin to take a nice long exhalation, you may feel a lengthening sensation through the anterior cervical tissues. You may have to add some side bending and extension and rotation to facilitate that length. But the key thing there is understanding that you need to consider the interaction between the thoracic spine and the rib cage. Instead of just looking at the rib cage and thoracic spine as moving as a single unit, we may have to consider them moving in opposition as well. So can the thoracic spine extend and the rib cage flex relative to an extended thoracic spine? Okay. Again, that's important when we're looking to, again, like I said, restore some eccentric behavior through the cervical flexors. So here we're looking at flexor loading strategies. The first one we're looking at here is a strategy to restore the capacity to distribute flexion across the thoracic spine and the head and neck. with more of an upper limb focus. So you can characterize this as more of an indirect loading strategy. So we'll bring this up on the full screen here. So this is a loaded strategy. Sometimes clients may need an unloaded strategy to begin with. But when we walk the knees closer to a foam roller here, what it does is it brings the humerus into a less of a range of humeral flexion. So it brings it lower into the range of humeral flexion, which allows us to get a little bit more thoracic flexion. Okay, so it's important to bring the knees nice and close when we're trying to concentrate that thoracic flexion. So this would be helpful for clients that have limitations in thoracic in thoracic flexion. Yes, when they're more extended through the thoracic spine. Okay, so get the knees nice and close. We're allowing the head to flex. We're reaching through the arms, generating that scapular protraction, and then adding a head flexion with that as well. So we're trying to, one, concentrate some of that flexion through the upper cervical spine. Okay, but then we're also trying to actively pull the chin towards the chest to actually get some load through the cervical flexors here. Okay, so we are distributing flexion across the thoracic spine here into the cervical spine, but this is generally helpful for clients that struggle to concentrate that flexion through the cervical spine, and they can't actually get that load into the cervical flexors here. So we can utilize this as a strategy to help to restore thoracic flexion, but also as a way to restore some load through the anterior cervical spine in clients that are sensitive to concentrating that load through head flexion or cervical flexion in isolation. Okay. So generally what we'll do first, again, is we'll translate the body forward to get more load into the upper limbs, try and maintain that reach, maintain that thoracic spine flexion to the ceiling, maintain that scapular protraction, and maintain that gentle loading of the head into flexion. So we're actually getting some light load through the cervical flexors here. But the segmental interactions is important here. We're flexing both the thoracic spine and the head together, especially, like I said, in those clients that are sensitive to head flexion. If you can distribute flexion first, it offers the individual a chance to experience load through those muscular tissues. Because generally, I think if we're trying to concentrate motion too quickly or too early on, where we're trying to narrow the focus on the cervical spine, we risk getting too focused with our attention, and that reduces the amount of load that we can actually deliver to the system. So we may be able to, get some local range of motion back in a segment or a joint structure or a joint interaction, but have we actually restored some load into the muscular tissues at the same time? Okay. Another strategy that we often like to use here, it looks like a little bit of a funny one, like I'm going for a snooze here, but what we'll get the client is into a seated position, cross the arms across each other, and then get a little bit of flexion through the thoracic spine and some flexion through the head into the arms now. Because if you consider the supine head lift or chin tuck, for example, where we're then hovering the cranium off the table in a supine position, where we're trying to get load into the cervical flexors, that's a very challenging one to sustain for long periods. Very often clients may have too much sensitivity to actually lift the head from the table. This is characterized by more of an overcoming strategy, where the client's in charge of how much contractile intensity they're expressing here. So, and we're also, again, distributing that flexion across the thoracic spine and the cervical spine and head. So again, it typically is a less sensitive strategy for us to experience that load through the anterior cervical spine. So I'll have the client, again, not just drive the head into the forearm here, but try to actually flex the head into the forearm. Okay, like we're trying to nod the head into a yes motion and then build pressure forward and down. And what you'll actually feel here is a nice concentration of load into the cervical flexor. So I encourage you to try this to see how you feel. But again, a really nice, focus of this one here is to ultimately restore the ability to sense that load moving through these tissues. Okay, if we're doing it in a supine position, we're not really giving the system and the tissues enough time to experience that load, to build those capacities, to handle those forces over sustained periods of time. So we can manipulate the duration here very easily. We can also manipulate the intensity of the contraction. So we can have the client build pressure down with 1, 2, 3 out of 10 level of tension relative to their 100% maximum force capacity. Okay. Here we can sustain that that force production for a longer period of time by reducing the intensity, okay? And you will experience a lot of load through the anterior cervical spine there, okay? But in a way that allows us to distribute that flexion, okay? But with an overcoming bias. Those would be, characterized by, again, movements of the head and the ribcage, thoracic spine, the same direction. But then we want to be able to restore that direct load into the cervical flexors with more of a dissociation interaction, where we actually allow for the ribcage, thoracic spine to extend and the head to be able to flex and get that load into these tissues while they're expressing more concentric behavior or more shortened position, okay? So we'll usually use a block up against the wall here. And again, what we'll do is we'll encourage the client to get that extension through the thoracic spine, flex the head as if we're nodding in a yes motion, and then build that pressure through the forehead into the block on the wall here. But you can see how now we're getting more of a concentration of flexion at the cervical spine now, because the thoracic spine is in more extension. Okay, so if you imagine I'm in a supine position here, if there's a treatment table on my back now, again, that would almost kind of characterize the same type of, head movements. But now we have a bit more control over how much intensity we're actually expressing by building pressure into the block. Much easier for the client to control at home, and allows us to sustain that contraction for longer durations. Okay, so hopefully you can see the difference there. Initially, we're looking to distribute that flexion and get load into the flexors, because again, we're talking about flexor loading here. And then we want to begin to restore some dissociation between the rib cage and head as we continue to get some load to the flexors. Okay. Again, this clinical reasoning tip, we've just discussed this already before, where if we have a client with poor thoracic flexion, again, we want to distribute head flexion and thoracic flexion first, particularly if they're coming to see us with a limitation in head flexion, but they also have thoracic flexion limitations. Distribute flexion first. If the client has poor thoracic extension, like I said, we wouldn't necessarily try and drive the client into more thoracic extension. We would typically try to restore some variability in the thoracic spine first, because again, when we move into thoracic extension, that would demonstrate a movement into a position of less variability of the thoracic spine. It's important to facilitate certain motions at the cervical spine, but within the thoracic spine, it demonstrates less variability. So that's important to consider, that within thoracic spine variability versus how the thoracic spine moves to facilitate movement in a neighboring body region, the cervical spine in this case. Okay. So now let's move into some extensor loading strategies. Again, still staying in the sagittal plane here. But first I want you to consider, how does the supine position influence neck motion? Okay. So we'll show you that here in this video. Again, we'll put it up into the big screen there. So in a supine position, again, the treatment table will actually provide a constraint in terms of how much motion we can actually facilitate at the cervical spine. So if I have Rachel reach the arms towards the ceiling here, we're actually facilitating some thoracic flexion. You can see, because the head is staying in contact with the treatment table, what kind of behavior is facilitated at the cervical spine. So we're going to get a little bit more flexion at the upper thoracic spine, a little bit more flexion at the lower cervicals, and a bit more extension at the upper cervicals. So if, for example, you have a client who is very flexed through the thoracic spine on the treatment table, but you're trying to get some load into the anterior cervical spine and some length perhaps into the posterior cervical spine, the cervical flexors, or the cervical extensors, I should say. Again, if the thoracic spine is already flexed, it's going to be very challenging to do this in a supine position. So that's why sometimes you'll see in the next few videos where we can work on restoring some variability in the muscular behavior through the cervical extensors in a standing position first, because it actually affords more variability in how we're manipulating load into the cervical extensors. Okay. Sometimes what you can do with a simple little tweak here is to actually bring the arms above the head, and that will encourage some thoracic extension and allow for the head to actually flex a little bit more easily, because now the upper thoracic and lower cervical is a little bit more extended, which allows us to get a little bit more flexion through the upper cervical spine. Okay, so you'll see that that extension at the cervical spine there. But if we drive the elbows into the table and really drive the thoracic spine rib cage into extension, you'll see how that encourages a little bit. It affords more capacity to flex the upper cervical spine. That's essentially what we want to consider there. Okay. If a client really struggles to extend the thoracic spine, then sometimes we can bridge the pelvis up, which will bring the thoracic spine into more extension in space, but relative to the head, the thoracic spine is going to be more flexed because it's going to encourage more thoracic flexion and lower cervical flexion, but it still brings the head into a position where it can actually flex more. You'll see that here. Okay, but again, you can hold that position there if you wanted to and build tension down into the head, into the table to get some load into the cervical extensors as they're expressing more eccentric, more lengthened behavior. But generally, we want to get into a position where we can extend the thoracic spine like this here. We'll get a bit of lumbar extension, of course, as well, and that to encourage more flexion of the cervical spine. Okay, but if we can't even get that thoracic extension, and we really want to get some length into the upper cervicals, for example, and we're in a supine position on the treatment table, then we may have to bridge the pelvis up there. It's an option. It gives you an option during treatment. So here we need to consider these kind of distributed motions again. And again, I mentioned it briefly before, from a coordinative standpoint, these would be referred to as in-phase patterns or freezing patterns based on the work of Nikolai Bernstein, where we can move one segment into a certain direction or into the same direction as another segment to facilitate motion, just like we did with the thoracic spine flexion to facilitate neck and head flexion. But we can also change the motion of the thoracic spine here, just like we did in the supine example, to facilitate a little bit more length into the upper cervical spine. So one strategy that we tend to use a lot, particularly when clients lack that variability in the upper cervical spine, is we'll actually utilize that same behavior like we just showed, where we position a block behind the head. And then what we'll actually do is we'll walk the feet forward to encourage this lifting of the thoracic spine, which does bring the upper thoracic into more flexion, the lower cervical into more flexion as well, relative to the head and the upper cervical spine. But what it does is it encourages more freedom of motion to get that length here. Okay, so you can see my thoracic spine is shifted forward, but this affords a greater capacity for me to experience load in that manner through the upper cervical spine. Okay, so we're utilizing this to almost give the client the experience of load through the upper cervical extensors as they're expressing more eccentric behavior. Okay, and then we can come back to trying to concentrate that extension, okay, or concentrate that flexion through the cervical spine, okay, and concentrate that eccentric load through the upper cervical extensors when we're in more of a supine position, where that concentrated flexion of the upper cervical spine is challenged more. Okay, so again, we're walking the feet away, we're flexing the head into an upper cervical nod, so we're nodding forward, holding that position, and then what we're doing is we're building tension into the block via the head to get some load into the upper cervicals here, and you really feel that nice lengthening through the upper cervicals here. But again, it's just one of many options that we can use to facilitate that muscular behavior. Okay, but you can see the position that we have to change through the thoracic spine to encourage that, and then we can add some dynamic motions here as well. What we eventually want to get to, though, is to build the ability to do this while the thoracic spine extends. Okay, the upper thoracic spine extends, the lower cervicals extend to allow the head to flex. So we're actually getting that dissociation where the thoracic spine extends and the head can flex. Okay, that's not what's occurring in this example here in standing, but it gives us the ability to experience that load with less coordinative demand. It's a less coordinatively challenging task, particularly for clients that struggle to dissociate segments. We have to appreciate that we can't just drive variability from the get-go with clients that have experienced less variability for a long period of time. It's almost like a learning process. So we have to appreciate that we may have to use these positions that demonstrate less variability through the segments, but that allow us to experience load through the muscular tissues while the muscular tissues express certain behaviors as well. We eventually want to get into a position like this where, again, the first example I'm going to show you here is less variability again, where we're bridging up. It makes it easier for me to flex the upper cervical there and drive load to the toe. Again, this is almost similar to the standing example. Again, sometimes it's a bit more challenging, but oftentimes it's a bit more challenging because we have to hold a bridge while doing it. But I eventually want to get to the point where I can get that extension through the thoracic spine by driving the elbows into the ground, and then encourage that cervical flexion. Okay, that head flexion to get some length into the upper cervicals, and then drive that load down into the towel here. I like to use a towel when I can because it just has a little bit of give, a little bit of yield to it to encourage a squashing of the head into that position. Okay, and then we can experience that nice load through the cervical extensors as they're expressing more eccentric behavior, particularly through the upper cervical extensors. Okay, and then we can move into some advanced extensor loading strategies using a foam roller here. So here, again, these are tough strategies where we position the foam roller just at the base of the occiput at the beginning. Again, we still want to get some load into the cervical extensors while they express more variability first. Again, generally we're looking to restore some variability by restoring eccentric behavior, because that eccentric behavior allows for sharing of stress across a broader surface area. We're reaching the arms into protraction here to try and reduce the contribution from the thoracic extensors. And then what we're doing is we're building tension down through the head and the upper cervicals into the foam roller here, and then trying to hover the thoracic spine from the ground here. So we're driving tension and then holding that position. So it's a very challenging strategy. You'll feel a lot of load through the posterior tissues of the cervical spine there. And then we want to make it harder by moving the foam roller higher up onto the back of the cranium. Same thing again, reach, little flexion nod, drive down, and then lift and hold. Typically we'll hold these for 5 to 10 seconds at a time, drop back down, then hold for another 5 to 10 seconds, and repeat for 5 to 6 repetitions. Then to really make it more challenging, we'll reach it up even further, we'll drive the load down, and then we can add some cervical extension to this, where we're actually getting more load to these tissues as they express more of a shortening behavior, more of a concentric behavior. Okay, the foam roller allows us to do this because the foam roller will roll underneath the head, and we can make this dynamic as well. So we can drop back down and move through the range of motion again. So we're driving down, but then we're looking up at the same time. So you'll see how we'll be able to concentrate more extension through the cervical spine here in this example. Just to show you again, reach to reduce thoracic extension contribution, drive down, and they then begin to look up at the same time. Okay, but generally first we're trying to get some load to those tissues as they express more eccentric behavior, and then begin to drive some load as they express more concentric behavior. Okay, so you can see that representation here using the wall strategy through the head and the rib cage here, where we have the head in the same position, but we're moving the pelvis and the thoracic spine forward by walking the feet out. This brings the thoracic spine generally into more of an extended position in space, but relative to the head, it's actually more of a flexed position through the upper thoracic and lower cervicals. Okay, which again makes it easier for us to get that upper cervical flexion. But again, it's using a less coordinatively challenging task. Okay, so now we're going to move briefly into some manual loading strategies. Again, these are strategies that can be helpful to restore some local variability in the muscular tissues, particularly in the frontal plane we tend to do them in. So again, the focus here will be restoring some variability through the upper trapezius, where we're actually trying to facilitate some eccentric behavior through the upper trapezius. Okay. The first one here is going to be more of a respiratory focus, where we have the client in a supine position. And again, to get some length into the upper trapezius, we do want that humerus to be a little bit more externally rotated, so it brings the scapula into more external rotation as well. Okay, what we're doing then is we're positioning our hand on the top of the shoulder, and we'll have the client take a gentle breath in. And then on the exhalation, we're guiding the scapula into more depression to allow the client to experience that lengthening through the upper trapezius. And we can pre-position the head into side flexion here away as well to further challenge that eccentric behavior. We can add some slight flexion and slight rotation towards to even further get that lengthening through the upper trapezius. Okay, but this is helpful for clients that typically when they inhale, you see a lot of activity through the accessory muscles, where this encourages a reduction in the demand of these tissues, because then when they inhale again, you're blocking that elevation of the scapula. Okay, so when Rachel inhales here again, I'm blocking that motion, and then when she exhales, I'm following a little bit more through that scapular depression range of motion there. If she feels some neural tension through the upper limb, then we can bend the elbow. Typically, that's what we'll do. So if clients have sensitivity through the peripheral nerves, again, which is very important to also assess and identify and potentially load when you have clients with cervical spine discomfort and sensitivity as well. We just haven't really addressed that in this masterclass, but again, we do address it clinically and certainly go through it in our courses as well. Okay. The next strategy here adds a little bit more focus on loading the upper trapezius as it's in more of a lengthened position. So not as much of a respiratory focus, but focusing more on driving load through the scapular elevators. So getting load into scapular elevation as it's in more of a lengthened position. So pre-position the head into a little bit more side flexion. Again, make sure that the humerus is a little bit more externally rotated, so that scapula is externally rotated. We can bring the scapula into a little bit more depression through exhalation, then have Rachel gently build some pressure up into my hand via scapular elevation to get some load into the upper trapezius as well. Okay, we can maintain that at a low intensity for long durations. Now, generally, when we are putting load through the cervical tissues here, we generally keep the intensity quite low to moderate, but change the durations. We like to change the durations first before we add more load to the cervical tissues, because typically these tissues aren't really dealing with a lot of direct load. So we like to keep the load low to moderate and change the duration of the tasks. And that's why we like to kind of use these overcoming strategies here, where the client has a bit more control over how much force they're producing in a way that allows them to sustain the contraction for longer periods relative to something else like a supine, chin tuck and lift, for example. Okay. We also want to then consider, how we can restore some variability through the scapula and begin to get some load into the upper limb. So, like I mentioned earlier, if we're trying to get some variability through the scapula, and we're trying to restore some upward rotation and protraction capacities through the scapula to try and isolate that movement through the scapula without needing the humerus to internally rotate, then we can use a strategy like this, where we're in a quadruped position. We can use a foam roller here to position the hand on with more external rotation. Again, we're bending the elbows there because, again, typically when you bend one side, sometimes if you're keeping the other elbow extended, that will just encourage a rotation of the thoracic spine away, which actually brings that scapula that you're targeting into the scapular plane. So it reduces the demand of the scapula moving into protraction. So we'll externally rotate, because then when we externally rotate, we challenge the ability of that scapula to protract on its own and upwardly rotate on its own. We can build some tension down through the hand, reach the elbow, and begin to roll the foam roller away. You'll typically feel a nice lengthening through the lats, sometimes in through the medial scapular muscles as well. But generally, we're trying to couple that with some load through form extension to get some load into the triceps here as well. Okay. Again, getting some variability to the scapula is very important, particularly if you identify some objective limitations in the movement of the scapula as well. So we can hold this statically in terms of building pressure into the foam roller, holding that position, or we can maintain the pressure and move dynamically. Okay, and we maintain a little bit of thoracic flexion there as well, because we're moving into the middle ranges of humeral flexion here. We're not really moving into the end ranges. So that would be a different strategy when we're trying to restore end range humeral flexion, or even trying to restore thoracic spine extension, where we actually want to encourage internal rotation of the humerus. And we actually want the surface that we have the hand on to be higher or at the same level as the shoulder, not below. Because again, we wouldn't really be able to move that humerus through end range humeral flexion in the previous video we just showed. But here now what we can do is we can position with the palm down. That allows the olecranon to face more laterally. That allows the humerus to internally rotate more. That allows the scapula to externally rotate more. And that puts the thoracic spine into a position where it can extend more. And then we can build some load down to humeral extension as well, to get some load through those humeral extensors when they're in more of a lengthened position as well. Okay. Generally, when we're trying to improve thoracic extension, we will often try to go through the upper limb first to encourage these segmental behaviors before getting a client over a foam roller, for example, because we just generally find that this encourages better thoracic extension behavior when we couple that with the upper limb first, instead of trying to direct load into thoracic extension or direct motion into thoracic extension first. Because sometimes if you have a client, for example, where they struggle to externally rotate the scapula, for example, and you just have them driving their thoracic spine into extension over a foam roller, you never restore the capacity of the scapula to externally rotate with humeral flexion, which is necessary to achieve thoracic extension with humeral flexion, then they're not likely going to engage with that thoracic extension when they get off the foam roller. And very often when clients are extending over a foam roller, they're typically just extending through the lumbar spine anyway, because the thoracic or the foam roller is just too bulky to be able to get that load into the thoracic extensors. Very often what we find even more helpful is to actually extend over a yoga mat, where you just have a slight roundedness there, where you can at least keep the lumbar spine a bit more flexed, so you're concentrating that extension at the thoracic spine more. Okay. Skipped some strategies here, actually, the transverse plane and frontal plane loading. So coming back to that there, where we're looking at some thoracic rotation. Okay. When we're looking at thoracic rotation, we need to appreciate the interaction between the thoracic spine relative to the scapulae, but we also need to appreciate the interaction between the thoracic spine and the pelvis, like we discussed earlier on, because if the pelvis is moving in the same direction, we're not actually getting any thoracic spine rotation at all. So that's why it's important to position a block between the knees to encourage a fixation of the pelvis. And what we like to do here is position the bench or a chair up against the wall. Position, if we're trying to rotate the thoracic spine to the left, we'll have the wall on the left-hand side. We'll position the right hand on the outside of the left knee and position the left hand on the wall. So we're actually creating this kind of pulling and pushing maneuver between the left hand and the right hand. And this allows us to get a little bit more aggressive with the rotation, but also reduces the contribution of the scapular retractors. Because oftentimes if you see someone doing like a rib pull maneuver, for example, sometimes you'll just see that scapula begin to really retract to try and get that rotation, without actually concentrating that rotation through the thoracic spine. So that's what I was trying to, to allude to earlier on when I was talking about that scapular retraction example. So here, because the left hand is pushing into the wall, you can almost think of the left scapula as biasing more protraction as we're rotating the thoracic spine and the rib cage relative to the scapula. Because when the thoracic spine rotates to the left, the spinous processes move to the right, which actually encourages a bit more lengthening of the muscular tissues between the spinous processes and the medial portion of the scapula. Okay. But again, one of the biggest reasons we will use a strategy here is because it's just easier to maintain the position and breathe in this position. Because what we'll tend to do is, again, you can see it as a strategy to improve thoracic rotation, but also we will encourage more head and thoracic spine dissociation in the strategy too, where we position the thoracic spine there and then focus on very slow motion controlled head rotations, particularly in the opposing direction. So nice and slow through the head as it rotates to the right here, but now the thoracic spine is rotated to the left. What you'll often see in clients is it almost looks like they have a bobblehead when they're expressing a lot of excessive muscle activity around the cervical spine, because it's very difficult to slowly allow that lengthening to occur in the cervical tissues and then concentrate that rotation on the vertical axis through the cervical spine. But it's even more challenging to do that now when the thoracic spine is rotated in the opposing direction. But because we have that push-pull mechanism through the hands here, it's much easier to hold that position of the thoracic spine as we rotate the head, versus trying to pull the thoracic spine into rotation and then hold that there as we rotate. There's just typically a lot more muscle activity being expressed across the thoracic spine in that example. So really nice strategy to restore some cervical, thoracic, or head and thoracic dissociation there. We can also use some of these standing strategies to get some load into the frontal plane through side flexion. So we'll position the block up against the wall there. We can encourage a little bit more dissociation through the rib cage and head by reaching that left hand down to the ground and then building tension through the head into the block. Okay, so the head is building into the block. Again, we can, like I said, we can drive some scapular depression there, which will drive some rib cage depression on that same side to get some length into these tissues. But then what we also like to do is to encourage a bit more rotation of the thoracic spine towards the wall there, to encourage a bit of dissociation between the head and the ribcage thoracic spine as we begin to load into side flexion. But we can add also a slight bit of side flexion and rotation into the block. Okay, and then begin to continue to rotate the thoracic spine towards the wall to encourage that dissociation. But like I said before, having the block against the wall and the freedom of thoracic spine motion here gives the client control over how much force they're producing. So I don't mind if the client has to produce 1 out of 10 pressure and experience some load through those tissues. If we can sustain for a longer duration and then use that to build up that local capacity, that local muscular capacity around the cervical spine. And then we can add some rotation between the thoracic spine to encourage more variability on a segmental level as well. Okay, so while they may look simple, they're very, very helpful for restoring for building direct load or driving direct load into the cervical tissues, but also, allowing the client more control so we can progressively load them a little bit more easily. Okay. And then we're moving lastly into a coordinative strategy. And you can also see this as an indirect perturbation, okay, where we're trying to encourage a lengthening of the upper trapezius, for example, and then simultaneously drive that load into the upper limb. So position the hand on the wall here, turn the chest away. We don't necessarily have to turn the thoracic spine to the point where it's parallel with the arm. So at this moment here, my humerus is actually in the scapular plane now. Okay, again, I can progress this further by rotating the thoracic spine further to the left to bring the scapula into more external rotation. But what you'll see here in a second, I think I just already did it, was I encouraged a bit more of a proud chest to actually bring the thoracic spine to more extension, okay? Because I want to actually encourage a bit more length through that upper trapezius, okay? In order to encourage some length through the upper trapezius, the scapula needs to be in a little bit more external rotation and then depression to try and drive that length into those tissues, okay? Then what I'll do is I'll take some load off the right leg, so I'm leaning into the wall. You can also add a little bit of side bend away to encourage that length into the upper trapezius, and then see, can we actually concentrate load through forearm extension there, which means we're concentrating load into the triceps there. Okay, we can hold that isometrically, or we can add some dynamic motion there. But now this is a sneaky challenging task, because very often what clients will do, particularly when they have poor load capacity through the upper limb, is they'll drive that load through the tricep, but then you'll see the scapula begin to elevate, because they can't actually concentrate that load into the tricep, secondary to muscle weakness, for example. Or they are so used to expressing this heightened level of muscle activity proximally that they can't actually separate the two behaviors. Can I get length and motion to the upper trapezius, some variability around the head and neck, as I actually get that load into the upper limb as well? This is one example as to what we can use, but again, it's a very helpful example. Again, I just had a client even today struggled to feel her triceps initially, but when we side bent the head away, bang, she felt the triceps kick in straight away. Okay, so again, there's many mechanisms behind that. There's many potential reasons behind that, but generally, again, she was using an awful lot of muscle activity proximally to encourage some load through the upper limb. So we have to try and separate those two behaviors, try and drive that load into the upper limb while simultaneously restore some variability in muscle and joint behavior proximally. Okay, but then, of course, what kind of muscular behavior, what kind of joint segmental behavior proximally you're going to facilitate will depend on your objective assessment. Okay, so hopefully that was helpful. We went through quite a bit of initial theory, went into some assessments, and then went into some loading strategies. Of course, this doesn't kind of represent everything that we do with the thoracic spine and cervical spine, particularly the head and neck. But we just wanted to try and kind of characterize and categorize the loading strategies in a way where we're looking at more direct load first, and then more indirect load, but also looking at more local muscular and joint variability, but also then more coordinative variability, where we're looking to restore load shearing across a broader surface area, like the upper limb, for example, while simultaneously restoring some relaxation and muscle activity proximally. Okay, so again, like I said, this is exactly what we go through in our courses. We discuss local muscular variability and joint variability behaviors. We try and identify those current capacities and then begin to, facilitate a rehab plan to load the tissues, to begin encouraging more variability and to build the low capacity of the system, but also simultaneously appreciating and integrating strategies that have an influence over the client's symptoms. Okay, so this is the roadmap that we work through. Again, if you're interested in learning more, please check out our courses. Both our level 1, level 2 courses will go deeper into these features. But once again, if you've made it this far, thanks so much for listening, and we'll see you next time.